What are we going to do with our patients who end up going to the ICU post-op? How do we transition these patients to the floor? And then how do we think about sending patients home? So let's start off with a case presentation. A 70-year-old woman who has a pre-op for a total hip replacement. She has a past medical history of hypertension and diabetes, but really has done well otherwise. She has medications including aspirin and hydrochlorothiazide and ACE and a statin. She's also on metformin. She's on glargine that she's getting 30 units every morning, and she gets aspart, 10 units with each of her meals. She doesn't have any chest pain or shortness of breath, can walk about 1 block, and she's limited by her osteoarthritis. Blood pressure's okay. Her weight's 150 kilograms. Otherwise, physical exam looks okay, and her EKG not too worrisome. Her lab tests show that her glucose is 190, creatinine's 1.3, lipids are actually pretty good, and her A1C, 7%. She's been doing pretty well on her aspart of 10 and her glargine of 30. So, what should we do with her meds on the day of surgery? A, should we continue her metformin and stop the insulin on the day of surgery? Should we discontinue her metformin and continue her glargine that she was taking 30 units at home every morning? Should we actually make that 15 and stop the aspart? Should we discontinue the metformin, continue the glargine at her home dose of 30 and stop the aspart? Should we discontinue the metformin, continue glargine at 30 and continue the aspart, or just wish the diabetes away? A, B, C, D, or E? Okay, and our answers are? Great. Most of you put B. Which was to go down to about 15 units of her basal instead of the usual 30. It would be okay probably to do the 30. I don't think that is necessarily wrong. But if you want to be on the safer side, I think doing 50% of her usual basal is a very reasonable thing to do. And that's what I talk about right here. We would stop her metformin, obviously. You would take her total daily dose of 30 units of her basal and probably cut that in half. So if you did anywhere between 15 and 30 units, pretty reasonable thing, and then stop the aspart. How often do we then check her blood sugars when she's NPO? We probably want to do that at least every 4 hours. And how can I remember what to do? These are some great references to look at when you're trying to come up with your own algorithm for your practice. Remembering that we have our basal insulin all day long and that we get our increases of insulin with each meal. And we're probably doing our most to try to copy this when we're doing our basal bolus kind of therapies with insulin. So she arrives in the pre-op area with a blood sugar of, let's say, 400. And you need to think about why in that instance. We talked about that earlier. Patients who are NPO with an A1C of 7% should not have a blood glucose of 400. This is wildly out of the normal for her, and you need to think about why that is, and maybe even thinking about canceling her surgery. This is not normal for her. 225, okay. Well, probably we just gave a little bit too little of basal insulin in this case, and maybe we're going to think about doing an intraoperative insulin drip or giving her a little bit of an aspart bolus. And then finally, if she came in at 115 to her pre-op area, fantastic. We're doing exactly what we want. This looks great. So surgery goes great. She's sent from the PACU to the floor. What diabetes management do you do if she had actually only been on metformin at home? Let's say she's not on insulin at all, she's just on metformin at home, and her A1C is 7%. Would you do a sliding scale? Would you do a basal bolus correctional with a total daily dose of 0.5 units per kilo per day? Would you do the basal bolus correction with a total daily dose of 0.3 units per kilo per day? Would you do a little metformin plus her sliding scale? Or let's give GenMed Consult a call. A, B, C, D, E. I know some of you would do E. I've worked with some of you. And let's see what our results are. So a number of you went for the basal bolus with the 0.3 units per kilo per day. Some of you did the sliding scale. You know what? I don't think this is a wrong answer to do sliding scale in this situation. Patient comes in just on metformin, is doing well with the metformin and an A1C of 7%. Sliding scale may very well be a very reasonable option. The 0.3 kilos per unit, the 0.3 units per kilo per day is a reasonable option as well as from the studies that I showed you previously. But either one, A or C, would be good answers for this. But let's say so the surgery goes great. She's sent from the PACU to the floor, but the diabetes treatment you start, what diabetes treatment would you start if she'd actually been on both metformin and the insulin that we had talked about, that she had been on that glargine of 30 and she'd been on that aspart of 10 with each meal, and her A1C is 7%. Would you do sliding scale only? Would you do the basal bolus correctional with a 0.5 units per kilo per day? Would you do the basal bolus correction with 0.3 units per kilo per day? Glargine at 30, her usual home dose, plus aspart of 5 to 10, depending on how much she's eating. Or the endocrinologist will be able to help us with this one. And the results here. And it's mixed. So probably in this case, I would probably just go with her usual home dose. She's done really well on her usual home dose at the 30 units of basal and the 10 units with her meals. If I'm not sure exactly how much she's going to eat, I think it's reasonable to decrease the aspart because you don't want to make her hypoglycemic with her meals. But going with her usual home dose, in this case with her A1C of 7%, it's working for her. So I think going back to that would be reasonable. The other options would also be fine. But I think the best answer in this one is probably going with her home dose since it has been working for her. So what happens, what diabetes treatment would you start? We just went through this. We won't go through this again. But remember to try to get her on a carbohydrate-controlled diet as well. But let's say surgery doesn't go well. She's had dramatic blood loss. She's hypoperfused. She likely aspirates. Her sugar spikes to 350, and she ends up going to the SICU. Let's talk about the ICU care. What are your goals for her blood sugar? Well, we just talked about that in the last topic. Probably somewhere between 140 and 200, and often starting the insulin threshold of around 180. Maintain the glucose in between that 140 to 180 range, and the targets below 110 and the targets above 200 are not recommended. How do we reach these goals? And I think the answer is the IV infusion if you guys can do it. If her mental status is not good, should we feed her with NG-enteral nutrition while she's on an insulin drip? And the answer is that's probably fine, although it certainly complicates matters, and you'll probably have to turn up the drip a little bit more as she's on her NG feeds. If her mental status is good, should you feed her while she's on an insulin drip? Let her just eat. And that really complicates things when you have bolus enteral nutrition along with an IV drip. But you could just add some short-acting sub-Q insulin when she's eating, and that would be fine as well, just thinking about your drip as your basal insulin in this instance. So intraoperative ICU therapy using your IV infusions is the preferred method, but you got to know what you're doing. There are lots of protocols. There are no right answers. The Endocrine Society recommends thinking about all of these different issues as you are coming up with your protocol. And there are computer-based algorithms that can help you as well that do seem to provide some tighter glycemic control without increased risk of hypoglycemia. And look at these references if you want to find some of these protocols and some of these references to the computer-based algorithms. And here are some more protocol examples, including what you can't see so well, the PortlandProtocol.com and the Yale protocol, which a lot of folks have been using. But the bottom line is when insulin infusion infusions work is because you guys are working with your entire staff to make it work. That you have glucose targets that are reasonable, that there are algorithms that you're using that you are validating for your own setting, and that the safety procedures are developed, and that it is a multidisciplinary process that is driven by the idea of constant quality improvement and quality assurance of the process. That's when it works well. If you are trying to do it siloed, it's not going to work well. So make sure that this is a total team effort. So how do you get the patient off of the drip? And when do you know that the patient can come off of the drip? Well, I think once they are stabilized, and you can see all of the different things that you can look for to make sure you feel like the patient is stabilized enough to come off the drip. And you want to make sure, obviously, that their glucose has been stable on the drip as well. So let's say this patient has met this criteria and she's been on about 3 units per hour for the last 6 hours or so, and her glucoses are doing pretty well. How would you know how to transition her off the drip? What kind of insulin regimen might you put her on? Well, if you had never taken care of her before, and she had no history of that she has done well with her diabetes treatment in the past, you might think about using the insulin infusion rate to help you figure out how much total daily dose of insulin you should give her. So what you can do is you can say, well, she's been on 3 units per hour for the last 6 hours. Her glucoses are really good on that. So about 3 units times 6 is 18. And if you want to do that over an entire day, well, that's 18 times 4 is 72. And now you've come up with a total daily dose for that whole day. And what people generally say is then take about 80% of that and make that the actual total daily dose. So that would bring you down to about 60 units for total daily dose. And then if they're going to be transitioned to a regular diet, you can take 50% of that for their basal and another 50% of that for their nutritional. Make sure, though, that as you are taking them off that drip and you're putting them on a bolus, on a basal treatment, that you give that basal treatment at least 2 hours before you stop that drip. Drip has a pretty short half-life. You want to make sure that they have some basal coverage because you are taking that drip, which has been your basal, and you are changing it over to sub-Q basal. Make sure that sub-Q basal has had time to kick in before you stop the drip altogether. And then obviously order the appropriate point of care testing. So our patient had been on that 3 units. We get that to be a total of 72 units over about a 24-hour period. If you take 80% of that, that brings you down to 60. If you do the basal bolus at 50-50, you're talking about 30 units basal. You're talking about 30 units of nutritional. And then you could take that nutritional and divide it between each meal, get you back down to about 10 units per each meal, which essentially was what this patient was on anyway. And then you add in your correctional scheme. Lots of different ways to do this, lots of different correctional factors that you can use and equations. Here, this is one where you do the 1700 divided by their total daily dose to come up with what the correctional dose should be. You can take a look at this. There's all sorts of different correctional formulas that you can use, and then many institutions have their own correctional schemes based on whether they think the patient is insulin sensitive, usual care, or insulin resistant, whether the patient has seen insulin before or not. All of these are reasonable to use. Just make sure you have experience with the one that you are trying. And I have over the next few slides, which we're not going to go over, different ways of dealing with these patients depending on whether you're using tube feeds or not using tube feeds. One of the things to keep in mind is if you are using tube feeds, you tend to then only give the patient about 20% of their total daily dose, and let me get on the right slide, about 20% of their total daily dose is their basal, and you give about 80% of their total daily dose if you're using tube feeds as their nutritional, and you spread that nutritional over the entire day, where you give 6 equal doses of short-acting insulin over the entire day since they're being fed all day long. And you can look at this for when the patient is NPO. A couple of things to remember. Does anybody use regular insulin anymore on the wards? If any way you can avoid using regular insulin, certainly on the wards, I would do it. It does have the risk of stacking, especially when you have patients with some renal insufficiency. And make sure that when you're using the short-acting insulin, give it right after the meal so you know how much food that patient has taken. That's the beauty of Aspart and Lispro and the other short-acting insulins, is they can be given right after the meal. They still will peak right away. They'll still help with that glucose, but you can avoid the hypoglycemia if the patient doesn't actually eat and you have given the short-acting insulin before their meal. And then how do I discharge? Well, I think it all depends on what their A1C was before they came in. So it's a good idea to take a look at what their A1C is to see if you think they're going to need to have adjustments to their diabetes regimen depending on how well controlled they were. If their A1C was above 7.5%, feel free to call general medicine consults or their primary care doctor and say, do we need to do any adjustments here? If they're below 7.5%, they're probably on the right path, and I wouldn't make any changes to their regimen from home. The final pearl, sliding scale insulin alone is not adequate for insulin-dependent diabetics. Make sure you are holding those oral agents when they are in the hospital. You can start the oral agent about a day before they're going to go home if you want to make sure that they're working right. When transitioning from IV to sub-Q, make sure you give that basal insulin dose before you turn off the drip. And patients previously receiving insulin must receive a basal regimen.